Live. And we are live. Professor Angela Maas, thank you so much for joining us and being the inaugural Menopause Research and Education Fund speaker, kicking off our Masters in Menopause series for this year. So wonderful. Let me give you a brief introduction. So you're a Dutch cardiologist with a special interest in women's heart health, especially around midlife and the specific risk factors that we face. You're also an expert in microvascular changes within the heart at Raboud University Medical Centre in the Netherlands, and the author of what I can say is actually one of the best books I've read in a very long time, A Woman's Heart. So all in all, since 1988, you have been working exceptionally hard on women's health and the gender differences that we face. But we are still underdiagnosed, treated late, worse outcomes.
I know.
Frustrating?
It is very frustrating. And I'm writing a next book, why it's going so slow. Because there are many factors involved why there's no change. And one of the factors is that medicine as a whole has been set up from the male perspective. And in the books, in all the education programs for doctors, for primary care, but also doctors working in hospitals, the standard patient is still a man. And it's not obliged to do courses in sex and gender differences in medicine. So in the Netherlands, you can do a course if you like, but if you don't want to, you don't have to. So there's no sense of urgency to make changes. And many doctors say, well, I don't discriminate. For me, all people are equal. But I think we have to make the difference when it's relevant. And if you look, for instance, at cardiovascular disease, the way our blood vessels and our heart ages is quite different among men and women. So we need to talk about that because we still do the wrong investigations in our female patients.
Unbelievable. To have a non-mandatory course and say you don't discriminate is, women are not small men. In terms of looking at the heart itself, is a woman's heart actually structurally or physically different?
Well, the heart is a muscle, in fact, and the weight of the female heart is lower compared to men. This is also why we have different categories in sports, because a man can have more strength compared to women. This is a fact. But also the diameter of the blood vessels is smaller in women. And there is a big role for the high level of estrogens in the blood vessels and the myocardium, so the muscle of the heart. And estrogen levels in women are much higher compared to men. And even at old age, the estrogens that we produce in our fat tissue in men and women have a different effect. So even when you are in your 80s, the effect is still different.
That's an interesting one, actually, because we got estradiol and estriol, and we change when we hit midlife. We change the one that we choose most. But we'll come back to midlife factors in a minute. But remind me of that if I don't throw it at you. When women actually do present with a heart attack, we present quite differently as well. Do we know why that is? Has that got to do with the different ways our heart is actually structured in the way the disease?
Yeah, well, an important factor is that many types of myocardial infarctions are different among men and women. And different underlying causes of a myocardial infarction lead to different symptom presentation. That's one reason. But also women do feel symptoms differently. and women communicate differently. So there are many aspects why their symptoms are different. For instance, if you have a myocardial infarction due to coronary spasm, which happens quite often in women, you will have fluctuating symptoms, a bit crescendo, decrescendo pattern. And that's not in the books. So often it's said, well, this is not what we expect you to have, so it can't be a myocardial infarction. And well, still nowadays, these mistakes are made. So we have to learn that the pattern of symptoms has more variety in females, which is okay. I mean, we can put it in the books and learn it. So what's the point?
It's an interesting, because if we're having these fluctuating symptoms as well, I mean, this may be an incredibly stupid question, remembering that I'm not a medic, but when you they'll do a blood test and they'll look for specific causes in that. Does that mean that they might not show up as well, and women will then be told, well, actually, you're not having a heart attack, it's just stress, or go home? Does this in some way to the fact that we're often dismissed and not diagnosed properly?
I know, but we have to look for the high sensitive troponin levels, and not only the pure troponin levels. So we have to make different laboratory investigations. And in men, we see more often a myocardial infarction due to a stenosis, which can be dilated with an intervention procedure. And in women, it's more a myocardial infarction due to non-stenotic cardiac disease. And that also leads to lower levels of the high sensitive troponins. So we have to take care of different levels of which is normal and abnormal among men and women.
Absolutely.
It's not the same.
Before we even get to a heart attack, there are, for women specifically, we have a number of risk factors early in life. We have got, if you have PCOS, that's a risk factor, gestational diabetes, preeclampsia, and now we have rising rates of obesity as well. When it comes to assessing cardiovascular risk, are they captured well enough, do you think, in the predictive tools that we have?
No, not at all. Not at all. So the answer is no. But we have to look, if we consider a patient, we have to look at a life course. And for instance, also in women having migraines since their teens, for instance, associated with their monthly period, but it can also be separately from this. Those are women who raise their hand at an early age to say that they have a higher cardiovascular risk. And PCOS is a disease of the ovaries, hormonal disturbance with fertility disorders, but also metabolic problems. And those patients are seen by the gynecologist. And if we want to innovate in healthcare, we have to collaborate together. And what you see too much in daily healthcare, that we are in our vertical different specialists. And the life course goes through all those different zones, silos, in fact. So the innovation in healthcare is at a crossroad of different disciplines. And I often go to conferences of gynecologists because I learn a lot about women's cardiovascular health from the gynecologist, not from the standard cardiologist, because they don't know it at all. So I think to ask for female-specific issues is very important. For instance, we are now starting to recognize that an early natural menopause before the age of 40 has a higher cardiovascular risk, whereas an early surgical menopause, when the ovaries are removed before the age of 40, doesn't seem to have a higher cardiovascular risk.
Oh, interesting.
So this is interesting because early natural menopause may be associated with early aging of the vasculature of the ovaries. Whereas this is not the case when you remove the ovaries by a surgeon or gynecologist, for instance, in women with higher risk for ovary and breast cancer. So there are all kinds of issues during a woman's lifetime that we can ask for. And these are not really risk factors, but we call them risk variables that are important to discriminate at midlife between a low risk and a high risk woman. That's the most important.
Absolutely. I'm putting myself out on a limb here for a second because I have a theory. And you mentioned going to gynecological conferences and you're learning a lot from them. Is there something that they can also learn from cardiologists? My theory being this, that if erectile dysfunction is related to microvascular disease, then why isn't GSM vaginal atrophy?
Yeah, well, of course, many of the leading doctors are men and more interested in erectile dysfunction than in vaginal atrophy. But I think perhaps a more relevant sign for cardiovascular disease is persistent vasomotor symptoms after menopause after the age of 55. Because the majority of women will have symptoms when entering menopause. That may take 5 to 10 years that they do have symptoms, hot flushes, night sweats, all that kind of things. But if those symptoms do persist when women age after 55 or even after the age of 60, those women have a higher risk for cardiovascular disease. They often have hypertension. So, we can use those symptoms also to discriminate again between low and high risk women. And this what gynecologists can learn from us.
Yeah, absolutely. The vasomotor symptoms, the European Atherosclerosis Society has put out quite a large paper towards the end of last year. And in that, they were talking about vasomotor symptoms being regarded as an independent risk factor. Do you agree? Do you think so?
Well, I think there's not enough evidence to put them into the risk charts, because we need large data sets and also combination of female specific risk variables to be able to put that kind of risk variables in a risk chart. And we are thinking about that with a group of interested cardiologists and gynecologists, but because many of those women are not critically followed for several years, we don't have enough evidence to give it a number, a risk number, for instance. So, but this is one of the things we have to do.
Yeah, absolutely. It's a high up there on the research list.
Yeah.
While we're on vasomotors and hormones and things around midlife, these change obviously, and you touched on it before. What's going on with the hormones and heart health around midlife? Why does it matter?
Well, we see a lot of changes when estrogen levels decline. Estrogens already start to decline at the age of 30 in women. So when we enter our 40s, it's more difficult to get pregnant. We all know that. And estrogen levels are lower. And we see all kinds of inflammatory comorbidities coming up. For instance, rheumatic symptoms, muscle symptoms, all kinds of inflammatory chronic diseases, but also, for instance, thyroid disorders. And these are also important comorbidities. But what we also see is that our risk factors change. Between the age of 50 and 60, cholesterol levels in women rise about 15%, whereas in similar age men, there is no change in cholesterol. We see a sharper rise in systolic blood pressure in women compared to men, starting from midlife to old age, towards old age. We see that the thrombotic system is at a higher level. And we also see that, our stress hormone system is also at a higher level. So estrogens are not only important for the reproduction, but for many systems that we have in the body. And when that changes, a lot of adverse effects happen in women.
Absolutely. You mentioned cholesterol there, so I will be jumping around here a little bit, and the changes in cholesterol. Now, one of those changes are changes in the low density lipoproteins,
Yeah.
and we have biomarkers of carriers, don't we, of lipoprotein A and apolipoproteins. I'm sorry if this is very complicated for people who are not doctors who are watching this, but different types of carriers of cholesterol that perform different functions that could actually be good indicators or risk factor markers.
Yeah, well, small particle LDL are more harmful. And we see that also fat tissue increases after menopause. We see it, we get more fat tissue at the wrong place in our, abdomen. And this also means that there's more inflammation involved, also in fat tissue, leading to the wrong kind of low particle LDL levels. But also, if we look at LP little a, we still don't know exactly what the impact is of LP little a on cardiovascular risk. But we see a change in women, a rise in women around menopause, whereas also in men, LP little a doesn't change. But we don't know yet whether LP little a is more harmful in women compared to men. We think so, but we're not sure yet.
Interesting. So in many ways, then sort of, there have been calls in certain areas to say that we should be measuring this later on in life for women,
Yeah.
but it will not necessarily give us much information at this stage.
No. We need more research specific with these questions. And these questions are quite recent, haven't been asked earlier. So if it was an issue 30 years ago, we would know it by now.
Yeah. The other thing that is an interesting with the buildup of plaques in the blood vessels are calcium scores. Is that something that we could make more use of in terms of predictive?
Oh yes,
yeah,
sure. Because to do a calcium score, in fact, what you do, you measure the amount of calcium in the vessel wall. And we know that there are differences among men and women in their lifetime. So we have different tables of what is normal at a certain age and what is abnormal. Women have less calcification in their vessels, but it gives you an indication of the biological age of your blood vessels. And in high-risk women, the calcium levels will be higher than in normal or low-risk women. So normally, women shouldn't have calcium below the age of 60 in their coronary arteries. But we know that many high-risk women already have calcium before the age of 50. So it's a very objective and reliable tool to assess whether a woman has a low or high risk at middle age. And this is one of the good things to see and to start prevention timely in those women.
Because I think here in the UK, and I correct me if I'm wrong, or anybody else who's listening can correct me if I'm wrong, but normally one wouldn't be done until you've presented with a problem. But would it actually be a quite useful and quite
Oh,
easy
yes.
to do earlier?
For instance, it can also be useful for gynecologists if they want to decide whether it's safe to prescribe hormonal therapy in a certain woman. But gynecologists don't know this kind of test. But it's done at a radiology department. You don't need a cardiologist. But we have to learn from each other. So this is what gynecologists can learn from us to work with it. And it's also not very widespread used in cardiology because there's also the financial thing that cardiologists are paid to do a bicycle test. But most bicycle tests are useless in women at middle age. You can better do a calcium score, but cardiologists are not paid for the calcium score. That goes to the radiologist. So there's always why.
Disincentives.
Yeah, and this is one of the reasons that we don't make any progress, because there's also the financial issue.
Yeah, absolutely. And that's good. And also, the money that the health systems would save at the beginning by doing that test, if you can get prevention always being cheaper in the long run than cure.
Yes, in the long run, but we don't think in the long run. You see it in politics. Politics is a matter of short run because, the politician wants to be popular and they don't want to look in the future. So this is why we're going so slow. And in the end, we spend too much money being ineffective.
Very true. I have a question over here for you from a lady who is a clinical lead director at a menopause consortium, and she's saying we're aware that POI is associated. We were aware that POI is associated with other autoimmune diseases. So interesting that the surgical POI doesn't have the same risks. So are we suggesting then that there is an autoimmune factor associated with cardiovascular disease in this group of women?
We don't know. We don't know. Perhaps it's one of the reasons, but it has been postulated already, I think 18 years ago, that an early natural menopause may be a sign of early atherosclerosis in the ovaries. So vascular aging, early vascular aging in the ovaries, which is not the case when you remove them surgically. But we don't know yet. But it's closely connected also to genetics, because you see it more in women with a high family risk of cardiovascular disease. You see more often an early natural menopause.
Right. Yeah, that makes sense as well. You mentioned earlier there as well statins. Now, I had another question come in from a woman who was saying that she's mid-50s, was pre-diabetic, is fine now, has no particular family history of heart disease, but all of a sudden her LDL and her total cholesterol has gone up. Her HDL is going 1. And so a lot of the rest of that is LDL, which is probably not looking particularly good for her. But she's been told overall that because she doesn't have a family history and her risk score is under 10, that she shouldn't have statins. So I guess the question out of that is, why do we have a target if it's a conditional target?
Okay, I think it's a very good point. I think it's quite old-fashioned to think that it's not necessary to treat that, because if you are in your mid-50s, your vascular age is getting up. And if you want to do adequate prevention to look 20 years ahead, you have to start early. And I remember the first statin trial in the Lancet in 1994, that there were only about 18% women included. And it has taken more than 10 years, perhaps 15 years in the discussion, that clinicians said, well, statins don't work in women. but we didn't have the right investigations. Women were not included properly in those studies. And now these things are starting again, because a couple of years ago, a study was published about an anti-gout medication in patients with chronic coronary syndromes, with angina, with established coronary disease. And again, there were only 16% women included. And I asked the investigators, why didn't you include enough women? Oh, we forgot about them.
There's only 51% of the population, easy to forget.
Only, so we are still a specific subgroup that doesn't need attention. And that's frustrating me and many women.
That I can understand. A question over here as well about HDL. After menopause, and we're told that this is a protective.
Yeah.
Does that protective facility change with menopause or after menopause?
Well, it seems that HDL doesn't change so much after menopause. But it's more the LDL that gives a higher impact, but also the combination of risk factors and risk variables after menopause. So also the combination with the rise in blood pressure, with the higher pro-inflammatory state, with the higher thrombotic state. So HDL is not a specific topic after menopause. It's more the combination of other things altogether.
Should we be having more of a conversation about it?
Of course. Why not?
Absolutely. You mentioned stress earlier as well in there. Do women deal with stress differently to men, and how does that impact on their heart health?
Well, it has an important effect. We know that men deal better with stress. Men can park stress until the next day. You know, men can say, well, tonight there's a football match, have a beer, and we'll see tomorrow. And this is not how women handle stress, because stress in the heads of women, it goes on during nighttime, and women want to solve problems. And we all know that problems will always be there. And women are also more, have more the tendency to be perfectionists. We want to do everything perfect, and we think we have to do everything perfect, and not necessary at all. So leave some things as they are and don't care about it. I think we should have a bit of that attitude. We have investigated stress in coronary, in SCATS patients. These are patients with a spontaneous coronary artery dissection. And we found, we see this kind of myocardial infarction much more in women. 94% of those patients are women. And we have seen that perfectionism is one of the main causes of this kind of myocardial infarction. These are quite healthy women between 40 and 60 with a low risk factor profile, but they do have a chronic stress and a tendency to do everything perfect. So this is quite important also when you want to treat those patients. You also have to focus on stress reduction, because these are young women. Some of those women are 43. They are in the midst of their career development. They have a young family. They still have their parents, perhaps some parents to take care of. And, they want to do everything perfect. And then all of a sudden they get a heart attack.
Yes, it's a very sad thing, isn't it?
But it's quite fascinating for research. And we only recognize those patients now since about 7 to 8 years. And in the past, we treated them wrong, because those patients, if possible, don't give them a coronary intervention when they enter the hospital. Do nothing.
Yes, it's interesting. There's a lady here who's just written about her mother who felt nauseous, vomited in the evening. They thought that she had a stomach bug.
Oh
Uh,
yes, that's a classical one.
yeah, and then was found dead at home alone after a couple of hours, just a couple of hours after saying that she'd felt unwell, which is just really sad.
Yeah,
It's
of course.
we
Yeah,
need to do better for women all round, really. One of the things that we definitely need to do better on as well is high blood pressure.
yeah.
People often say it's a silent killer, but it's not necessarily always silent, is it?
No, high blood pressure is the number one deadly risk factor in women worldwide. So about 80% of women will have sooner or later hypertension. And if you are above your in your 80s and you have hypertension for 30 years or more, you won't feel it because you're used to it. But the rise in blood pressure at middle age, when you are in your 40s, 50s, or even in your 60s, that gives a change because it may also cause symptoms like hot flushes, sleep disturbances, chest pain, pain between your shoulder blades, headaches, concentration disturbances, all kind of symptoms that we also attribute to menopause. So it may interfere with menopausal symptoms. And I've had so many women with this kind of symptoms and high blood pressure that I treated for their blood pressure, and they told me, well, now I also have fewer menopausal symptoms. I feel better. I have more energy. So this is not a solution for every woman. So there are women really in need for hormone therapy, but in women with these kind of symptoms with high blood pressure, treating high blood pressure is the first thing you have to do.
With often, you mentioned that with menopause as well, people will be on their HRT, they're going along quite swimmingly, and all of a sudden they'll find that their hot flushes are coming back, their migraines are coming
Yeah,
back,
yeah,
and they'll think, oh, I just need to up my dose of estrogen. Could we possibly be missing the high blood pressure then
yeah.
by thinking
I'm
that it is?
sure. I'm sure. And I often recommend women, certainly women who had high blood pressure in their pregnancy, at the start or perhaps at the end, uh, and also when high blood pressure is in their family, to buy a device to measure at home. And you can share it with your sisters, your neighbors, or your friends, whoever. And if you have a higher risk to develop high blood pressure when it's in your family, measure it sometimes at home. And for instance, every 2 or 3 months, you measure it at home. It's quite easy to learn. And if it's too high all the time, show it to your general practitioner and ask what can we do about it, because one measurement is not enough for the diagnosis hypertension. And we often attribute elevated blood pressure in women to stress. And this is also often what female patients will tell you when they get in. And when you say, well, your blood pressure is too high. And the women say, well, I had difficulties in finding the hospital, in parking my car, and I had a busy day yesterday, all kinds of arguments and excuses why they have an elevated blood pressure. But realize that, at the age of 60, more than 40, almost 50% women already have high blood pressure. So be honest about it and don't make too many excuses. And I have to say that I use medication for hypertension since I became 50.
Yep, yep, me too. But interestingly, this leads me to my next question, which is, again, there are targets. Now, for many years, we were told that, oh, look, as long as if it's around 140 on 90, you're okay. If it goes above that, well, we'll sort of keep an eye on it. And
That's
as
outdated. That's old fashioned.
So what should we be aiming for now, and how do we ensure that the message gets through to GPs that that these guidelines have actually changed?
Well, grade 1 hypertension now is when you touch 130 over 85. That's what we call grade 1, the start of hypertension. So in fact, you should be below that measure. But, you know, the levels change with aging. For instance, when you're above 70, your systolic blood pressure rises more and your diastolic pressure goes down. So the difference between high and low gets bigger. So from 55 onwards, look, for instance, at the systolic pressure. That's getting more important. And when you're above 75, you know, 140 may be good. You have to take care that at old age that you don't lower the blood pressure too much all of a sudden, because you will drop down, break your hip, and then you have other problems. But if you're 38 and you have a blood pressure of 135 over, let's say, 90, it's far too high at that age. So we also have to look at different age groups. And you know, every 10 years you have a bit different targets. And now the discussion, because at the same level of blood pressure, the damage to the heart, to the brain, and the renal system is higher in women compared to men. Also because the diameter of blood vessels is smaller in women. So there's now a discussion going on whether in the future normal values in women should be lower compared to men. And I think that will happen within a few years' time.
I was going to ask you that actually. Should we have lower
I think
levels
so.
than
But
men?
the evidence has to grow a bit more.
Okay, interesting one. Oh, I just lost my train of thought there, because actually I was so interested in that. Yeah, I know what I was going to ask you, and that was do we also need to work much harder on public awareness that this is an issue for women? I'll give you an example. A new ad has started here. I saw it on television last night with two police officers, one man, one woman, and the whole of the thing was skewed towards the man making sure he goes in to have his blood pressure checked. Are we still thinking of coronary heart disease as really only a man's issue?
Yeah, because still in women, coronary artery disease is underestimated. And this is also because women have fewer obstructions in their coronary arteries. So if you look at the big data of patients having had a coronary intervention, a stent or a bypass surgery, we always see 80% men and 20% women. And this gives the wrong perception that coronary disease is a man's disease, and it still happens every day. But what happens more often in women, and then we have 80% women and only 20% men, are functional disturbances in the coronary arteries. And this is what happens at middle age, between the age of 40 and 70. We don't see so many obstructions in women, but we see a lot of coronary spasm in the large vessels, in the microvessels, or a combination. And to establish this diagnosis, you need different testing. So you need focused testing to establish this diagnosis. And we know that even in the Netherlands, this is done in only a few hospitals. So there are still many cardiologists who can tell you, I don't believe in it. I'm not talking about religion. I'm talking about, you know, ongoing scientific evidence that the pattern of coronary disease is different in women at middle age compared to later age and compared to men. So we need to do a different test to have the appropriate diagnosis when women have symptoms.
And what sort of test specifically will we be looking at for those
Well,
microvascular?
it's a quite well. you can learn the test being a cardiologist, but it's an invasive test. So you do a coronary angiogram, and then followed by measuring the resistance in the microvessels, whether it's normal or not. And we have good material, good catheters nowadays to get that diagnosis. We have a good protocol, a very safe protocol. And you also have to provoke spasm in the coronary arteries with acetylcholine. And many cardiologists are afraid to do that. They think it's too complicated, dangerous for the patient. But no, if you have the good protocol, and we've done hundreds of those tests, it's a safe protocol. And, you come up with a clear diagnosis. And this is important because you have to know what is the main issue in this patient. Because if it's spasm in the large arteries, you give different medication than when you have a higher resistance in the coronary microvessels. You start with other medication. So we have to tailor treatment on the appropriate diagnosis. And if you don't come with a diagnosis at all, how can you treat those patients?
It's a very good question. Those microvascular changes, and Louise, I will come to your question in a second, and Sally, I will come back to you as well. Those, again, going back to prevention being better than cure, are there lifestyle things that we can do to reduce these microvascular changes as well?
Of course, lifestyle is, if you want to treat, lifestyle is always number one, number two, number three. But lifestyle factors cannot prevent us from aging. We do age. And in women having those microvascular dysfunction, we now know that chronic inflammation is one of the drivers of the stiffening of those microvessels. And of course, exercise and healthy diet and keeping up a normal weight is important. But still, when you have this, and there's also the genetic risk, which you can't change, you will get stiffening of those microvessels when you enter your 70s. And that will also lead to more heart failure in women with a stiffened heart. So this is, after 20 years, you get that problem. And, it helps to have a healthy lifestyle, but you won't be able to prevent all consequences.
Good point. Now, Louise's question over here is, she's a GP and functional breathing practitioner. She's saying there's a steep rise in sleep disordered breathing as women transition from perimenopause to postmenopause, which is associated with morbidity and mortality. Night sweats are also associated with untreated sleep disordered breathing. How we breathe while she's written quite a long question here. She's how we breathe while we're asleep can influence vasodilation and stimulate parasympathetic responses and reduce blood pressure, or can we breathe in a way that reduces oxygen delivery, causes vasoconstriction, increases sympathetic response, or increases blood pressure? So basically, focusing on breathing better, is that going to influence the way our heart?
Well, we know that good breathing exercises, like you can do when you do a lot of yoga, that it reduces stress, and stress has also an impact on your blood pressure. And so, of course, it may help you, but sleeping disorders are also closely related to hypertension, higher blood pressure. So with breathing exercises, you won't be able to prevent that you will get hypertension in the long run. So I think it's important, it's helpful, but it's not always the solution.
Yeah. The menopause in itself is there, you mentioned earlier about the what they call about using the calcium test as a good predictive measure for whether or not they should or shouldn't start HRT. We have what we call this window of opportunity, which is 10 years from when you start. You've had your last period, basically. Could this then, be used as a tool for women who are over 60 or are beyond 10 years in terms of starting HRT if they were having symptoms?
We don't know, but it may be perhaps an opportunity. Although HRT, when you prolong it after 60, won't prevent us from aging. We do age. And I think important in the 60 plus group is to really be keen on the traditional cardiovascular risk factors, because we know also those female specific risk factors like PCOS and hypertension in pregnancy. After 65, the traditional risk factors, hypertension, lipids, and insulin resistance, they take over. So in the older age group, 65 plus, these are the crucial risk factors. Prolonging HRT, I think sometimes I do it. Sometimes I suggest, for instance, not to have it every day, but a few times a week. And if needed, you can take a year to stop it. Don't stop HRT cold turkey, because, not in one moment. You can take a year to stop it. And if you are 60, you can prolong it until 63, but I don't like women above 65 having HRT. That's a bit a disagreement I have with gynecologists, because they think differently about that. But I can't recommend it, because after 65, you are really aging. Your vessels are aging, and I wouldn't do it myself.
Interesting, because I guess the theory is that estrogen being theoretically cardioprotective.
Not at that age. Not at that age. Not above 60. Not above 60. No.
Is it perhaps also the mix then of the estriol as opposed to the estrogen, or do we just not have enough data?
Well, in fact, we do have enough data, because the Women's Health Initiative study published in 2002 was on women with a mean age of 67 years. So those women were too old for HRT, and we saw more cardiovascular problems. And of course, the hormones.
I would argue that study, they were put on later. They had risk factors beginning, and different type of HRT.
Of course. But it's not true that if we prolong HRT above 60, 65, that it's protective. That's not the indication for HRT. We shouldn't do that, because it also affects your thrombotic system. It's not recommended. No. Yeah.
No. We are living longer, though. So how do we get these risk factors into, because yes, we do age, we can't avoid that, but to stop me from having to ever come and see you, not that I'd love to come and have a cup of tea with you, but in a professional manner, to stop me from ever having come and see you, what's the best way for patients to actually do that?
I have to do something on my laptop. Oh, sorry.
That's all right. Oh, I've lost you. She's gone to black. I hope she'll be back. But in the meantime, we were almost done, so I will come back to your question should she pop back. If not, I'm guessing... I wonder what it's done. I don't know. We shall wait. Oh, there, no, yes, no. I can hear.
I'm back.
Ah, brilliant.
I had a low battery. I'm sorry.
Ah, that's all right.
Can you see me? No.
Can't see you yet, but that's all right. I can hear you, which is the most important thing. There
Okay,
you are.
I'm back.
We're all plugged in and back again. Yes, in terms of for patients, making sure that we don't that we can avoid seeing cardiologists. What's your take home message?
Well, I think the most important is for women, take your symptoms seriously and don't hide behind stress. Of course, stress is important, but if you have symptoms, take them seriously. And you should expect from physicians nowadays that you get a good answer why you have symptoms. My patients have been my biggest motivation. In the beginning, 30 years ago, I didn't have answers and I felt terrible about it. And I thought, well, I can't have my whole career saying stupid things to women. And I've learned the most over the past decades by listening to women. So take care that your doctor listens to you and gives an appropriate answer and, a next step how to deal with your symptoms. But it all starts with taking yourself seriously.
Very, very true. And in terms of, I'm just going to go back to Sally's question here because I forgot to ask it for her, if I can get it back. She had cardiomyopathy. Her mother had it. They both had early menopause. Is there a relationship between the two? Could the cardiomyopathy have had any influence on early menopause?
Yeah, well, there are different types of cardiomyopathies. So I don't know exactly what she is talking about.
Hypertrophic.
Hypertrophic. Yeah, I think the most important is genetics. And it may be that there's also a genetic risk related to early menopause. You see that from mothers to daughters. So perhaps she may have several higher risk, but in general, you can't say that a cardiomyopathy is associated with an early menopause. No.
All right. Now, you mentioned patients taking themselves seriously. In terms of take-home messages for doctors, what would you be urging them to do with midlife?
Well, I would like to invite you to read more about the progress we have made over the past 30 years in women cardiovascular health. And menopausal age is no longer a gray zone in healthcare and also not in cardiology. So learn what the progress that we have made and practice the progress, and that's important. So consider your female patients really as being different from your male patients. Make the difference.
Yeah. The in terms of, you mentioned research, so what's next for you? What are you doing research-wise? And you also mentioned you have a new book coming. So what are you up to next?
Well, the new book is going about the current culture in medicine, why it prohibits the progress in female health. And that's a very difficult subject. I do it together with a journalist because there are so many factors involved, but also the culture in healthcare and those who are at the top of the chairs of departments, the professors. And everyone says, well, there's so many women going into healthcare, but not at the top. Those who make the decisions, we need more women there. Because women will put women's health higher on the agenda if they have the opportunity. And this also accounts for cardiology. The cardiology culture is not so women friendly. And I remember in the 80s, we laughed at women because they had such stupid symptoms, They were stupid women, and we still are very biased about how we think about women with symptoms. It's a bit, I feel ashamed often. So this is the book, and I'm doing research on the association between endometriosis and cardiovascular risk. Endometriosis is also a chronic inflammatory disease, And we're now doing a project with a female head of Department of Gynecology, looking at those patients specifically for their cardiovascular risk. We also are testing new devices with a smartphone in women with microvascular disease to reduce their stress as a trigger for symptoms. So all kinds of studies, and I raise money for more research. So I do a lot.
You do
But together with together with other people. Alone, you can't change anything.
No, and there obviously you need a small army, I think, to get a lot of this changed. It's
A big army. Yeah.
well, that's no mean feat for you to tackle in the near future. We can come back to this in 20 years' time, because I mean, if you started in the 80s and 90s, and I remember in this book you were saying how hopeful you were for the future, but then
Yeah, but the
just
progress is too slow. So we need to go faster. And I'm writing about it, what to do.
Well, when is that out? Do we know?
Well, in fall, I think in October, November, but the first version will be in Dutch. So it will be, if it's going to be translated, I don't know, that will come next year, in a year's time, in English. Yeah.
Well, I hope it will be, and I'm sure it will be. Is there anything else, in parting words, you'd like to sort of get across to people? Because I know that you have things to do, like getting that book done. Any parting words?
Well, I hope that you learned something from this discussion, and there are still many gaps in knowledge that we have, and good ideas. The best ideas come from the patients, because they bring in what's wrong and what we should learn in medicine. So. And be critical to your doctors. I mean, we're not stupid anymore. So ask them what you want to know.
Brilliant. Thank you so much for joining us. Truly appreciate it. And this will, for those of you watching, Tara, you were asking where can you see it. It will save to the Harley Street Emporium YouTube, and I will upload it to the Menopause Research and Education YouTube channel as well. So it will be there as a reference for everybody to watch. Thank you again for being our first Menopause Research and Education Fund Menopause Master Speaker. And hopefully we can talk to you again next time when the new book is out, in Dutch or otherwise.
Okay. Thank you, Fiona.
Thank you
all for listening. Thank you.